Hello, my name is Daniel Lewis. I will be presenting with Twakila Favra, Lily Gaucher, and Jessica Sykes. Today we'll be presenting a case study on stroke. What is a stroke? A stroke is a brain attack, meaning it occurs in the same way that a heart attack does, only it affects the brain instead of the heart. A stroke occurs when the blood supply to part of the brain is suddenly cut off. This happens when a blood clot blocks off a blood vessel, or when a blood vessel breaks and spills blood into the brain, resulting in injury to the brain tissue. There are two main types, and then there is another type of stroke. Your first two are ischemic stroke and hemorrhagic stroke. And in an ischemic stroke, what happens is blood supply to part of the brain is cut off because a blood clot has formed in a blood vessel. Blood clots can travel to the brain from another artery, or they can come from the heart. Hemorrhagic stroke happens when a weakened blood vessel ruptures and bleeds into the surrounding brain. Blood spills around in the brain and creates swelling and pressure and damages the cells and tissue in the brain. Now, the third type of stroke is called a TIA. It's called a transient ischemic attack. And a transient ischemic attack is caused from blood flow to parts of the brain that are restricted for brief periods of time. Because the blood supply is restored quickly, brain tissue does not die as it does in a regular stroke. These attacks are often early warning signs of a stroke. The only difference between a stroke and a TIA is that a TIA is temporary. Signs and symptoms of a stroke: sudden numbness or weakness in the face, arm, or leg, especially on one side of the body; sudden confusion, trouble speaking, or difficulty understanding speech; sudden trouble seeing in one or both eyes; sudden trouble walking, dizziness, loss of balance, or lack of coordination; sudden severe headache with no known cause. Risk factors of stroke: modifiable ones include heart disease, high blood pressure, tobacco use, diabetes, high blood cholesterol, physical inactivity and obesity, poor diet, carotid or other artery diseases. Uncontrollable risk factors include increased age, gender, hereditary and race, and prior stroke. What to do if you think you might be having a stroke? The best acronym for this is FAST. FAST is an easy way to remember the sudden signs of a stroke. When you spot the signs, you'll know that you need to call 911 for help right away. F stands for facial drooping. Does one side of your face droop? Is it numb? Ask the person to smile, and if the smile is uneven, you'll know that that is a sign for stroke. Arm weakness. Is one arm weak or numb? Ask the person to raise both arms. Does one arm drift downward? Speech difficulty for S. Is the speech slurred? Is the person unable to speak or hard to understand? Ask them to repeat a simple sentence like, the sky is blue. Is the sentence repeated correctly? Does it sound normal, like the way they usually sound? And T stands for time to call 911. If you know that anyone is showing any of these signs or symptoms, call 911 immediately. Now, our case study involves a 64-year-old obese African-American woman named Mary with a sedentary lifestyle. Now, Mary is transported to the hospital emergency department for new onset of numbness and lack of coordination in the left arm. 911 was called 15 minutes after onset. By the time the patient made it to the ED, her symptoms had resolved. Now, the patient's blood pressure, once she got to the ER, was 207/84, and her heart rate was 130. Her EKG reflected uncontrolled atrial fibrillation. Now, her NIH stroke scale was 0, indicating normal neurological function, and her blood glucose was slightly elevated at 181. Now, Mary's CT scan was negative for any hemorrhage. An MRI showed patent vessels. An echo was done, revealing an ejection fraction of 60%. An ejection fraction of 60% means that 60% of the total amount of blood in the left ventricle is pushed with each heartbeat. This serves as a general measure of a person's cardiac function. A normal heart ejection fraction may be between 55 and 70%. Now, Mary is diagnosed with trans-ischemic attack, and she is admitted to the hospital's neurology floor with telemetry services for observation. During her hospitalization, she is evaluated for uncontrolled diabetes and treated for hypertension. Now, her past medical history includes type 2 diabetes, hypertension, obesity, hyperlipidemia, and gastroesophageal reflux disease. Mary is discharged the next day. Now, her assessment of her lifestyle and habits. Mary eats fast food frequently. She has a sedentary lifestyle. She is a real movie buff, loves her TV, loves the internet. Now, she weighs 230 pounds and she's 5'3", which makes her BMI 40.7. She has poor body image due to depression. Interventions we would do as nurses would be to interview the patient for family history risk, and evaluate patient's personal lifestyle and even habits that she can change. Stage 1, as I said before, BMI is 40.7, sedentary lifestyle, habitual fast food consumer, obesity history, and poor body image. As I said before, we are going to interview for risk factors in her family and in her. We're going to evaluate the patient, their lifestyle and their eating habits, and we're going to identify that BMI category to try to help educate her. Now, her non-modifiable risk factors include her age, her gender, heredity, and race. Her modifiable risk factors include high blood pressure, diabetes, high cholesterol, and obesity. Now, her high blood pressure is #1 cause of stroke. Her diabetes increases her risk of stroke because it can cause disease of the blood vessels in the brain. High blood cholesterol increases the risk of blocked arteries, and obesity can increase the risk of cardiovascular disease. All these factors are modifiable, and if managed, can reduce the risk of her having another stroke. Now, diagnostic testing that was done was to determine her type of stroke. A CT, which is a computed tomography scan, was used radiation to create a picture of the brain. Now, the CT scan can give valuable information about the cause of the stroke and the location of the extent of the brain injury. An MRI was done, which is a magnetic resonance imaging. It uses a large magnetic field to produce an image of the brain. The image produced by the MRI is sharper and more detailed than the in computed tomography angiography, a CTA, a special contrast dye is injected into the vein and images are taken of the blood vessels to look for abnormalities. Now, the MRA, which is a magnetic resonance angiography, in this test, blood vessels are imaged through a scanner to locate cerebral aneurysm. In cerebral angiography, a substance is injected into the blood vessels and an X-ray is taken. This gives a picture of the blood flow through the vessels. This can show the size and location of the blockages to be reviewed. Now, education needed would include dietary modification materials, diabetes management, blood pressure management information, and information on having a healthier lifestyle, active lifestyle. Medications needed by Mary would include an antihypertensive for her high blood pressure, an anticoagulant to thin the blood, for the AFib, a medication for the AFib to help regulate her heart rate and reduce the risk of blood clots. An antiplatelet agent used to prevent platelets from sticking together and forming a blood clot. Cholesterol medications are used to prevent the building of plaque along the blood vessel walls, and an hyperglycemic medication to help control her diabetes and decrease her blood sugars. Now, what are the questions for stage 1? What are some of her non-modifiable risk factors, and what are some of her modifiable risk factors are the two questions we'll be asking. Now, her non-modifiable risk factors or uncontrolled risk factors include age, hereditary, gender, and race. Her modifiable risk factor is high blood pressure, tobacco use, diabetes, high blood cholesterol, physical inactivity and obesity, poor diet, and any carotid or artery disease. Thank you.
Hi, my name is Lily Gaucher, and my part of the case study is going to be focusing on the physician's orders. So as we all know that Mary has been hospitalized for a stroke workup. Some of the labs that came back indicated that her A1C was 7.9, her random blood glucose 181. She had an admission blood pressure of 208 over 84, heart rate of 130. So as a result of the left-sided numbness that she was presented with at the hospital, also with the left arm coordination, the doctor ordered specific orders based on a stroke workup, because based on the symptoms, it appears that she did have some type of stroke. So there was a CAT scan of the brain ordered, an MRI was ordered of the brain, an EKG. There was also a diet that was put in for her, which is a cardiac carb consistent diet, which is usually given to patients based on the heart healthy recommendations. She also was given a sliding scale insulin order to control her insulin, and then of course physical and occupational therapy, so that once the patient has been discharged, we will be able to know, prior to the patient being discharged, we'll be able to make an assessment as to whether or not she does need some additional support or any type of assisted devices. So with that being said, what do you think would be at least 2 home meds that are most common for the patients now that the patient has been diagnosed with a TIA? And another question would be, is this patient now at risk for an additional stroke? So anytime, it's most common that when a patient has a TIA, they are sent home with a low dose aspirin, typically 81 milligrams, as we all know that aspirin helps thin the blood. So if there's any type of occlusion going on, that'll help the blood to flow more freely. Also, the therapy with the statin drugs. Statin drugs are really good to lower the cholesterol levels of those patients, because once again, this patient has had some type of occlusion. Although it was resolved, this patient did have an occlusion, and we want to be able to safely send this patient home with medications that would help to prevent future stroke. So that goes to answering the last question, that yes, now that this patient has had a TIA, this patient is at risk for having another stroke. So it's important that, again, this patient is compliant with their home medications. They were compliant, obviously, with the medications that were given while the patient was there. There was proper education that is also needed to be given at the bedside prior to discharge, and also mention of any type of follow-up appointments that's necessary when a patient comes in under a stroke workup. So those are the orders, those are the home medications, and thank you for listening.
So I'm Jessica Sykes, and I'm going to be going over the portion of our case study that encompasses stage 2. So we've already talked about our patient, Miss Mary, African-American female, and she's now been admitted to the hospital. So the patient had a new onset of numbness and lack of coordination in her left arm. She gets admitted to the hospital, and she was actually diagnosed with a transient ischemic attack and atrial fibrillation. We know this because on our assessment, her blood pressure revealed her blood pressure was 207 over 84. Her EKG indeed confirmed the atrial fibrillation with a heart rate at 130. Her blood glucose levels were 181. She had a CT scan that was negative for hemorrhage, so that means she has no bleeding in her brain. Her MRI and her MRA showed patent vessels, and she had an echo, which is basically an ultrasound of the heart to let us know how effective the heart is beating. So it showed an EF of 60%, which is great. Unfortunately, Miss Mary is in atrial fibrillation. Her blood glucose levels are elevated, so we do have to intervene with medications. So we're going to administer metoprolol and diltiazem by mouth per our physician orders. Your metoprolol is a beta blocker. Your diltiazem is a calcium channel blocker. Used for blood pressure, but in this instance for Mary, we're going to use it to help her arrhythmia. We're also going to contact a physician for a sliding scale because her blood glucose levels are 181, and we want to definitely correct those because they're high, so we want to give her some injectable insulin. And we're also going to titrate the diltiazem drip as needed for her new onset atrial fibrillation. So here are some questions. How would you evaluate the effectiveness of the diltiazem drip? And what to do if the patient's blood pressure has a dramatic drop from the original admission blood pressure of 207/84 to 100/68? So a couple good answers for that is, how do you know the drip is effective? Well, you know the drip is effective if it's keeping the heart rate below 100 for one, because if the heart rate is over 100, that will be called uncontrolled AFib. So we want to get the heart rate below 100 to keep it controlled, and we want to eliminate the atrial fibrillation altogether. Another key indicator is if Mary goes from atrial fibrillation into normal sinus rhythm, and we can see this because Mary has been admitted to a telemetry unit, so Mary's wearing a telemetry monitor that keeps up with her heart rhythm and rate at all times, which we would also order a 12-lead EKG to confirm that she is indeed back in sinus rhythm. Let's talk about the blood pressure. So the blood pressure is much lower. It's not fatally low. She's asymptomatic at this point, but just in case. So if her symptoms at any time were not asymptomatic, what would our interventions be? So if she was asymptomatic, you would just continue to monitor the patient and her blood pressure. If she became symptomatic, then you would apply a few liters of oxygen via nasal cannula, 2 liters. Definitely contact a physician. Every hospital has emergency standing orders, so if her systolic blood pressure is less than 90, you definitely want to bolus the patient. We never mentioned in her health history that she had congestive heart failure, so we can indeed go ahead and give Mary a bolus of fluids to help with her blood pressure and the volume. And then, of course, you want to consider stopping the diltiazem drip, even though we are on the drip for an anti-arrhythmia medicine, but it does affect the blood pressure as well.
Hello, my name is Twyla Favroth, and I'm here to talk about stage 3 of the presentation. Prior to the patient being admitted into the hospital, the patient's signs and symptoms of numbness and lack of coordination of the left arm resolved inside the emergency room. The patient prescribed the patient to stay in hospital for 48 hours for observation. These are the discharge assessment figures prior to her getting discharged. So as we can see, her blood pressure is slightly elevated, which she's being treated with metoprolol. She has EKG of 98 beats per minute with some atrial fibrillation, and she is being treated with diltiazem. Her blood glucose level is 110, which is within therapeutic range, but she is being treated with Novolog and Lantus. Her MRI was patent vessels, and her CT scan was negative for any kind of hemorrhaging, and her echo was 60% ejection fraction. Now, what is the dietary guidelines for warfarin? What is the antidote for it? and what is the dietary restriction of Delteism. Now, warfarin, you should always monitor for any type of bleeding, rectally or urinary bleeding, nosebleeds, excessive bleeding. You should not play contact sports because of the bleeding risk. You should always want to wear a bracelet stating that you are on this medication, and so the doctors and others can know exactly what's going on if they see increased bleeding with you. Now, the doctor did end up prescribing her warfarin, and it was probably just a precaution for her atrial fibrillation, and that she had transient ischemic attack, which can cause strokes. Now, the antidote for warfarin is vitamin K. So we must always watch our vitamin K intake, and the dietary restriction of Delteism is grapefruit and grapefruit juice, because it increases the absorption rate of the medication. Now, the discharge instructions would be to call 911 for any numbness or drooping of the face, any slurred speech. Also, if you have any kind of confusion going on, please call 911. Seek help immediately if you notice any kind of bleeding or vision loss, or feeling dizzy or anything in that nature. Now, we also would like for you to contact the healthcare provider if your blood pressure is not within therapeutic range that was recommended by the physician. Now, that means if it's too high or if it's too low, that means that something may be wrong, which may be internal bleeding, or just needs to be, the medication may need to be altered to bring you into that therapeutic range. Always educate the patient on the medication that they're taking. Now, the patient here is taking metoprolol for her blood pressure. The warfarin is being prescribed for her atrial fibrillation and the risk of the blood clotting and causing stroke-like symptoms. Then she is taking Lantus, which is a long-acting insulin. She's taking Novolog, which she should take with meals. And then she's also taking warfarin, which causes the blood to not clot so easily, so that she's not able to have, well, she has a less chance of getting a stroke or transient ischemic attack, but has to be monitored daily until her therapeutic levels are met. Now, prevention is always the key. Now, we must manage our health conditions. That means seek medical help as needed. We must always maintain a healthy weight, try and get some exercise, and we should try a variety of healthy foods to maintain our health status and that low weight. And never use street drugs, and try to decrease the chance of you smoking, because this can cause strokes.